Here's what's coming up on today's edition of the Downsized News. Novo Nordisk is pushing for FDA restrictions on compounded semaglutide, threatening affordable access to these medications by 2025. Meanwhile, Eli Lilly's upcoming financial report could give us fresh insights into the future of GLP-1s like Mounjaro and Zepbound, and perhaps even the higher dose vials we've been waiting for. Plus, New York City employees are losing coverage for weight loss drugs, raising questions about healthcare access as the fight against obesity evolves. Stick around, there's a lot to unpack.
Welcome to the Downsize News. Today is Monday, October 28th, 2024, and we're thrilled to share the latest updates and insights on GLP-1 medications. I'm Lorraine Durham, and I've achieved a weight loss of over 50 pounds using compounded tirzepatide, which is also known as Zepbound and Mounjaro.
And hello, I'm Christopher Durham, and I've lost 81 pounds using these medications. Today, we'll discuss everything you need to know about GLP-1s, including Mounjaro, Zepbound, Wegovy, Ozempic, tirzepatide, and semaglutide, and anything else that comes along.
Before we dive in, just a quick reminder, we're not doctors. While we love talking about GLP-1s and weight loss, it's important to consult a qualified healthcare professional before starting any weight loss medication or treatment.
Plus, don't miss out on Downsized Live this week for Halloween. It will be Wednesday at 7 p.m. Eastern Standard Time. And of course, we dive deeper into your questions and connect with you and just have a great time.
Let's jump into today's news and explore what's new in the world of GLP-1s. In our first story, last week we covered the breaking news that Novo Nordisk filed a request with the FDA to restrict compounded semaglutide. And now we have more details on what's at stake. Novo Nordisk, the company behind Wegovy and Ozempic, is asking the FDA to add semaglutide to the demonstrable difficulties for compounding, or DDC list. If approved, this could heavily limit access to affordable compounded alternatives by early 2025, a move that will impact many people managing obesity and diabetes. Novo Nordisk argues that compounded versions of semaglutide pose serious safety risks. Unlike FDA-approved medications, which use precise recombinant DNA technology, compounded semaglutide relies on synthetic peptides. Tests have found impurities like amino acid substitutions, degraded molecules, and chemical modifications, which could lead to ineffectiveness or dangerous allergic reactions, including anaphylaxis. There's also concern about inconsistent delivery. Compounded medications often come in vials or pre-filled syringes, which expose them to contamination, and oral versions lack the SNAC absorption enhancer found in Rybelsus, reducing their effectiveness. Between October 2018 and June 2024, 542 adverse events, including 10 deaths, were reported to the FDA in connection with compounded semaglutide. Novo Nordisk warns that the real numbers could be higher since compounding pharmacies aren't required to report adverse events like manufacturers are. This situation feels eerily similar to the compounded tirzepatide crisis we are living through, which left many patients distressed and unsure of what would happen next. If the FDA agrees with Novo Nordisk at the October 29, 2024 hearing, it could mean fewer options for GLP-1 users. We'll continue tracking this vital story and bring you the latest updates. Don't forget to check out our original coverage from last week and stay tuned for what's next.
So it's important to note all of that list of terrible things, that's all a contention by Novo Nordisk. They're saying, oh, it's bad, it's unsafe, it's all these things. Compounding, as we know, those pharmacies are state regulated. Compounding has been around, honestly, since the beginning of our country. I mean, there have always been a pharmacist that would mix up new things for you. Story number 2, Eli Lilly will release its third quarter 2024 financial results this Wednesday, October 30th. Following the announcement, Lilly will host a conference call at 10 a.m. Eastern Standard Time, offering investors, media, and the public a detailed breakdown of its performance. This call may provide insights into Lilly's growing portfolio of GLP-1 medications, including Mounjaro and Zepbound, as well as an exciting roster of new GLP-1s and other drugs in development. A live webcast of the conference call will be available through Lilly's investor page. We'll leave a link in the description if you'd like to watch it. Of course, we will cover the call by focusing on financial performance, updates to Lilly's GLP-1s, and the future of obesity and diabetes care. Who knows what they'll announce? Maybe, if we're lucky, they'll release the higher doses of the Zepbound vials.
Yeah, maybe. You know, it's funny. A viewer sent me a message through Facebook with a copy of an email they received today from Eli Lilly. And the viewer thought that it was an email announcing the release of more doses of the vials. But in actuality, once we read through it, it was only announcing that the shortage was over for the pens. And she said, I don't know why I got this email today. And I was like, oh, well, I'm on the email list too for your medication. So I went and looked. I didn't get the email today.
No.
So they seem like they're testing something. I don't know. We'll have to stay tuned.
Honestly, it just feels like the whole marketing and PR arm isn't connected and talking to each other.
In our next story, New York City employees will soon lose coverage for popular weight loss drugs like Zepbound and Wegovy, as the city's health plan will stop paying for these medications starting in January 2025. According to Emblem Health, which administers the city's employee benefits, nearly 1,000 workers and their dependents had started using these drugs earlier this year under an optional prescription rider, only to learn that their coverage was provided in error. Liz Garcia, a city spokesperson, confirmed that the inclusion of GLP-1 medications for weight loss was unintended. The city never planned to cover these drugs due to the steep costs that would fall on the employees in the form of higher premiums, Garcia said. Moving forward, the city will only cover GLP-1 medications when prescribed to manage diabetes, not for weight loss. Medicare has long been prohibited from covering weight loss medications, but the recent FDA approval of Wegovy for reducing cardiovascular risks has prompted discussions about expanding coverage. However, Garcia noted that due to budgetary constraints, New York City's health plan would not extend coverage for these medications. Emblem Health informed affected employees that while weight loss coverage will end in January, those with current authorizations for these medications will be allowed to remain on them until June 2025 or until their approvals expire, whichever comes first. Earlier this year, Emblem Health required participants in the city's plan to enroll in WellSpark, a lifestyle program designed to encourage healthy habits in order to maintain access to these medications. As New York City phases out weight loss drug coverage, the decision highlights the broader struggle within the healthcare system to balance costs with growing demand. The affected employees are left with limited options: either cover the steep out-of-pocket expenses or explore compounded versions of these medications. For now, the city's health plan will maintain its stance. GLP-1 drugs remain available for managing diabetes, but not for those seeking to lose weight.
Well, you would say.
That's quite a bummer if you're a New York City employee.
Well, and you notice they added one of the whole maintenance programs. Basically, it's you need to prove to us that you've tried to lose weight before we allow you to
go on our lifestyle program over here. I think Blue Cross Blue Shield that we have also offers something like that. They don't make it mandatory, but
well, they don't cover our medications anyway.
No, but it behooves the insurance companies for people to create healthy habits. You'd think it would also behoove them to have people lose weight.
Well, the real problem is at some point they're performing medicine. So if they're saying this medication that my doctor prescribed is not what I need and I should do X, they're behaving as a doctor, not as an insurance company.
Well, they're just not covering it. You can still buy it. We're not going to cover it.
I don't know. It's just something's not right there. Yeah. Story number 4, a new study published in the JAMA Network Open reveals a significant shift in obesity treatment trends as the use of GLP-1s has soared while bariatric surgery rates have dropped. Conducted by researchers from Brigham and Women's Hospital, Harvard T.H. Chan School of Public Health, and the Brown School of Public Health, that's a lot of schools, the study found that the use of GLP-1 medications more than doubled between 2022 and 2023, while bariatric surgery saw a 25.6% decline during the same period. The researchers analyzed insurance claims data from over 17 million privately insured adults diagnosed with obesity, excluding those with diabetes, between 2022 and 2023. Their findings revealed that GLP-1 usage increased by a staggering 132.6% in 1 year, from 1.89 to 4.41 patients per thousand, while bariatric surgery rates dropped from 0.22 to 0.16 patients per thousand. Our study provides one of the first national estimates of the decline in utilization of bariatric metabolic surgery among privately insured patients, corresponding to the rising use of blockbuster GLP-1 drugs, said Dr. Thomas C. Tsai, senior author and metabolic bariatric surgeon at Brigham and Women's Hospital. The rise of GLP-1s, or as we know, Mounjaro, Zepbound, Ozempic, Wegovy, etc., offers an appealing alternative to surgery, especially for patients seeking non-invasive weight loss options. However, the report notes that only 5% of patients in the study received GLP-1s and 0.3% underwent bariatric surgery. An overwhelming 94.7% of patients did not pursue either form of treatment. The research also highlights differences in patient profiles. Those undergoing surgery tended to have more complex medical needs than those prescribed GLP-1s. They go on to say, while GLP-1 offer effective treatment for obesity and related conditions, they come with challenges, including high costs, limited availability, and side effects such as gastrointestinal discomfort that may cause patients to stop treatment. Physician Tsai noted he emphasized that metabolic bariatric surgery remains the most effective and durable option for obesity treatment. Now, turns out he actually does that surgery, so it might be in his best interest. Another physician, Dr. Atif Marota, MD, MPH, co-author and chair of the Department of Health Services Policy and Practice at Brown University, underscored the need to monitor these trends. Both GLP-1s and metabolic surgery are effective interventions, but fewer than 6% of patients in our study received either. There is a real opportunity to improve access to both of these life-saving treatments. The findings suggest that GLP-1s continue to grow in popularity. The landscape of obesity treatment is rapidly evolving. However, the authors caution that more research is needed to understand the trade-offs between surgical and pharmacological interventions. As we continue our own adventure using GLP-1 medications, this study underscores an important shift. More of us are battling the disease of obesity. They're choosing these medications over surgery. However, it's crucial to remember that no single approach works for everyone, and ensuring access to every treatment option is essential. So we've talked to lots of people who've had these surgeries, right?
Bariatric surgery. The problem with bariatric surgery, from what I've heard from bariatric patients, is that it does not last long term. You can stretch your stomach back out over time. You can eat more over time. People have gained weight in the 10 or 20 years following a bariatric surgery.
That's the argument we get over everything, right?
Well, and it's, on a GLP-1 medication, you lose 50 pounds, 100 pounds. You stop taking the medication, and what happens? Oftentimes, you gain weight back. But I would think a bariatric surgery would be far more expensive than a year's worth of
Well, it's covered by a lot more insurances, though. I think I could have actually had it, right?
Our insurance covers, you could have had bariatric surgery. Yeah. They will not cover you or I for a GLP-1 medication. So you'd think at some point, I wonder how much a bariatric surgery costs. $10,000, $20,000?
There's lots. I know a number of the folks who we've interviewed have talked about it. It also doesn't address that food noise, right? That extra thing in your head saying, eat.
You still want to eat all the time. You just physically can't, or you will hurt yourself.
And I agree with the doctors. I think the more options we have for treating obesity, every patient's going to be different. Everybody needs to have a personalized treatment for them. So it's great to see both options available.
And while we're talking about all this, let's talk about Club Downsized. Club Downsized provides additional benefits for those who wish to support us even more. Enjoy perks like loyalty badges, early access to videos, members-only live streams, exclusive Facebook groups, and personalized monthly coaching sessions with either myself or Christopher. Become a member of Club Downsized today. You can click the join button for more details.
Yeah. Story number 5. Today we're breaking breaking down the latest developments in Medicaid's evolving relationship with GLP-1 weight loss medications. These drugs, like Wegovy and Zepbound, have shown incredible promise in helping people manage obesity, as we know, but they're expensive. At around $900 a month, it's really made states hesitant to cover them. A new report from Kaiser Family Foundation, or KFF, reveals that while all state Medicaid programs cover GLP-1s for type 2 diabetics, only 13 states cover them for obesity treatment. But here's the exciting part. Half of the states that don't offer coverage yet are actively considering it. This could mean expanding access for those of us battling the disease of obesity.
That's right. What's interesting is the balancing act state officials are facing. On one hand, these medications are expensive, and that's been a significant roadblock. But on the other hand, these drugs could help prevent severe health conditions, potentially saving states a lot of money in the long run. According to the KFF report, Medicaid spending on high-cost specialty drugs, GLP-1s included, has skyrocketed in recent years. Between 2017 and 2023, prescription drug spending grew by 72%. That's a big reason states are being so cautious.
Now that the COVID-19 public health emergency is officially over, and has been for a little while, state Medicaid programs are shifting focus. They've just wrapped up a massive review of their enrollment lists, removing those no longer eligible, and are preparing for 2025. But it's not just about numbers. Many states prioritize reducing health disparities, improving access to behavioral health care, and addressing social factors that affect people's health. One example is how states are rolling out new federal guidelines allowing Medicaid to cover temporary housing and meal assistance. It's about tackling the root causes of poor health outcomes, and I think that's an exciting development.
Absolutely. And let's not forget that many states are also putting health equity into the spotlight. They're working with managed care organizations to create health equity plans, train staff on implicit bias, and track data on racial disparities. Some states are even offering financial incentives to insurers to reduce these disparities. That's a huge step forward.
Even though there have been many positive changes, states are facing some severe financial pressures. Healthcare costs are rising. Most states expect Medicaid spending to increase by 7% in 2025, even though fewer people are expected to stay on the program. The KFF survey found that many states anticipate budget shortfalls, so they'll need to make tough choices.
It's definitely a challenging time. States are navigating uncertainty with elections around the corner and ongoing workforce shortages. But despite these challenges, they're still making investments where they can, like increasing provider rates for home-based services, behavioral health providers, and nursing homes. That shows a real commitment to improving care even when budgets are tight.
Looking ahead, it'll be interesting to see how this plays out. Medicaid officials know that expanding coverage for GLP-1 medications could have a considerable impact, but they're also keeping a close eye on the bottom line. Whether or not they decide to cover these drugs, the choices made in the next year will shape access to obesity treatments and other critical services for years to come.
That's what makes this such a pivotal moment. For those of us battling the disease of obesity, having access to effective treatments is life-changing. But it's not just about us, it's about building a system that works better for everyone.
Absolutely. I mean, I think if nothing else, just over the last year of us being on GLP-1s, I've learned so much about how ineffective our healthcare system is and how convoluted and disturbing. And we learned what a PBM was, and that still makes no sense that it even existed.
Yeah, I've never heard of that a year ago.
So everything we can do to improve our healthcare system, it's a great idea.
Mm-hmm.
All right, well, that wraps up today's edition of the Downsized News. We hope you found the updates helpful and insightful as you navigate your own GLP-1 adventure.
And I hope you will visit our Downsize store at thedownsized.org to explore our selection of GLP-1 companion products and much more.
Before we wrap up, if you've enjoyed following the adventure Lorraine and I are on and want to stay updated with real stories, insights, and tips about GLP-1 medications, please like this video and subscribe to our channel. Hit the notification bell so you don't miss our latest updates and live broadcasts. Your support helps us grow and continue sharing valuable content with those of us battling the disease of obesity.
See you next time on the Downsized News. I'm Lorraine Durham.
And I'm Christopher Durham. We are the Downsized.